you all, the speakers, the august audience who are joining us live from different parts of countries and continents on this prestigious Asia Pacific Spine Society webinar Basic Spine series, this is the second in the series of basic spine webinars under the aegis of prestigious society Asia Pacific Spine Society. We have a very strong lineup of faculty with huge experience on cervical trauma, which is the theme of this webinar. Without much ado, may I take this opportunity to welcome our own dear Dr. Prof. Kwan, the President of Asia Pacific Spine Society, to please deliver the welcome address to all our listening delegates. Dr. Kwan.
Yeah, thank you, Vishal. So on behalf of the APSS, Asia Pacific Spine Society, I would like to welcome all the audience and participants to this webinar series. This webinar series have been started approximately 3 years ago and was welcomed by many participants around this Asia Pacific region. So for today, this webinar will be addressing on the basic spine and entitled cervical spine trauma. So the online education committee have invited many experts from the Asia Pacific region, from India, Bangladesh, Malaysia as well, to join this webinar to share their experience. So Asia Pacific Spine Society are very committed in terms of providing education and research to all the spine surgeons around the Asia Pacific region. So I hope that this webinar is one of the efforts to make this thing happen. So I would like to take this opportunity to thank the online education committee, Vishal and the team, for creating such a nice, wonderful program so that the expert can share their experience with us. And also thanks to Kaylin as well Auto TV for making this happen. And lastly, thanks to all the audience participants. I hope that you enjoy this webinar.
Thank you, Prof. Kwan. Wise words of wisdom, and I'm sure all the delegates who are joining us today will be enjoying this intriguing, interactive discussion on the common and yet delimitous topic, controversial topic on cervical spine trauma, covering all the aspects, right, from craniovertebral junction, Hangman's, odontoid, and subaxial trauma, and the commonest problems of facet dislocation, which are going to be discussed today. Without much ado, moving on to the academic program, may I call upon the moderators for today, Dr. Chikit and Dr. Vijay Loya, to please start the academic program and allow us to delve into the academics of Asia Pacific Spine Society Basic Spine Webinar on Cervical Spine Trauma. Dr. Chikit and Dr. Vijay Loya, over to you.
Yeah, thank you. So without any delay, it's our privilege to invite Dr. Sharif Ahmed Jonayed to present on management of subaxial cervical facet dislocation.
So thank you, Dr. Kit. So welcome you all to APSS second basic spine webinar on cervical trauma management. Today I will talk on management of subaxial cervical facet dislocation. Basically, you know that cervical facet dislocation are part of spectrum of injuries that include the ligamentous injury, facet subluxation, dislocation, or fracture. It is most frequently seen in young men with history of high energy trauma like motor vehicle accident, fall from height, or sports injury. But it also seen in low energy trauma with pre-existing degenerative pathology, spinal stenosis, or osteoporosis. So these sorts of injury must be diagnosed quickly and treated urgently. Unfortunately, optimal management of these injuries remains still controversial. If we see the mechanism of injury, it is obviously a flexion distraction type of injury. It can be either the unilateral or can be the bilateral. When there is the rotational component is present, it is usually unilateral. But if there is a more osteoligamentous, more type of injury, it is obviously bilateral in bifacetal involvement with more neurological deficit. We have lots of classification system. Among them, the Allen Ferguson system is the most important one. it again divided into the 4 subtype. You can see here the stage 1 is the facet subluxation, stage 2 is the unilateral facet dislocation, and stage 3 is the bilateral facet dislocation with less than 50%, more than 50% of displacement. And when there is a complete dislocation, it actually called stage 4. What's the mechanism? Actually, you can see here there is a tension band failure that ultimately leads to the lengthening of the posterior column with the possible compression of the anterior column. That eventually leads to the anterior translation of the superior vertebra as well as the facet subluxation and dislocation. That is important for our management purpose. Though there are other classification systems like AO spine system, or I mean the subaxial injury classification system. Actually, these are important for making decision when to operate or not to operate. So whenever a patient of subaxial cervical facet dislocation, your patient may present it with either axial neck pain or may be presented with paresthesia, palsy, or weakness at the level of exiting nerve root. So this patient may have the incomplete spinal injury or may have the complete spinal cord injury. Of course, so these have some goals. What it is? It is the protecting the spinal cord, decompressing the neurological element, and restoring the mechanical stability to the spinal column. So initial management, our aim is to protect the spinal cord as well as to protect from the ongoing damage from the continuous compression of the fragment. So initial management should be aimed at medically stabilized according to ATLS protocol, as well as the emerging injuries should be treated first in order to priority. Once your patient is hemodynamically stable, the spinal injury can be assessed and be treated. And later on, the neurological evaluation should be performed, documented initially, and continuously monitored throughout the course of the treatment. You can do either X-rays, CT scan, and MRI. If you see that there is less than 50% involvement, there may be chances of unifacetal dislocation. If you see that in X-ray, if it is more than 50% displacement, it is obviously a bifacetal dislocation. And in this patient, CT scan is very much important. Why? Because it takes only 2 to 3 minutes. And by doing the CT scan, you can know about the details about the facet, lateral mass, lamina, and body. That will help you to guide the planning of the treatment. And MRI, of course, it is necessary even in case of intact neurological patient. But question is, when should we do MRI? Should we do MRI before the reduction? Is it really safe? Or we should go directly to the open reduction? Let's see what's the literature says. In a 1200 patient retrospective series, it clearly shows that only 11 patients, that comprises only 0.92%, has a new permanent neurological deficit. And it shows only 1.7% of transient deficit. So both the studies, it clearly shows that close reduction is safe and chances of neurological deficit is very, very less. So in another studies regarding the AOA close reduction, in Rizulu, in his study shows that he did 55 patients of pre-reduction MRI. Among them, 54% has disc herniation, but there is no single neurocompression in awake and alert patient. Another studies also shows that there is no correlation with the outcome. And Beckeru, in his studies, it shows that MRI did not predict the neurological deterioration. So what is the decision? Decision is like that. If you can do the close reduction, if you see that close reduction, if it is failed, since there is a higher chances of anatomical obstacle like facet fracture or disc herniation, and obviously this patient should go MRI prior to open reduction. And if you see that there is a disc herniation, in that case, anterior, the approach is must. So next controversy is timing for reduction. As you have know that is very much important, because country like ours, it is sometimes seen that patient may present it in late. But what the literature said, it is actually done as soon as possible when it is safe. Safe means when the patient is physiologically stable, hemodynamically stable, competent surgeon is available with a suitable environment. So in Newton et al. Shows that if it is done within 4 hours of injury, it shows a good neurological outcome. So this reduction can be done either by gradual or rapid or manipulation under general anesthesia. I am coming one by one with advantage and disadvantage of each procedure. Suppose if you are doing the gradual reduction, that is frequently practiced in our settings, you can apply the trunk traction and 5 to 10 pound in every 30 minutes, and you can assess the neurological examination as well as the radiological assessment, whether it is reduced or not. And maximum weight that you can apply maybe the 30 pounds and until the reduction or up to the 72 hours. Advantage is that as the patient is awake, neurological monitoring is very easy. But on the other hand, it takes long time and success rate is only 55%. Whereas in rapid reduction, that should be done, of course, in a settings with ICU setup, where both the radiologist, surgeon are stand by the patient with the aid of the C-arm. And you can start with 10 pound. Remember, 10 pound in every 10 minutes. So it's a very big amount within a very short period of time. Once you have attained the 50 pound and if you see that there is not still reduction is not still not achieved, so you need to counter traction. So another thing is that, so when you should know that what is the end point. Suppose if you see that your reduction is achieved, that's good. But if reduction is not achieved, but there is neurological deterioration, destruction is more than 1 centimeter, or reduction is very unlikely. So in that case, you may need to stop the procedure. Advantage is that in rapid, this procedure you can reduce up to 88% as per literature shows. But disadvantage is that there is a still chances of over destruction and neurological deficit. So another option is manipulation under general anesthesia. We usually not recommend this because it requires a very highly experienced surgeon. Although success rate is very high, but there is still chances of neurological deficit that may not be unrecognized. If it is done, of course, it should be done under the neuro monitoring. In general, whenever the patient, if the patient has unilateral dislocation, it is not reduced easily. So that's why somebody advocate to do it operate. But in case of bilateral dislocation, it is reduced very easily with a very good success rate. Next question is surgical treatment. As you have seen, if the patient is, if your patient is not reduced or contraindication for close reduction, in that case, you have to do the surgical treatment, or even the patient is reduced, the facet is reduced, but for a better standard care, to maintain the stability and for fusion, surgical treatment is necessary. Again, there is controversy regarding the timing of surgery. What is the ideal time? In one article, the Vijay et al. Shows that if the surgery is done within the 72 hours with a very good neurological outcome, whereas the failing groups, they show this time is fine. That means if you do surgery within the 24 hours, that means it has a very good neurological outcome with a good recovery. So in our setting, sometimes it may not be possible, but you have to judge according to your structure, the manpower available or structure. So whenever you consider the surgery, you can do either anterior, posterior, or combined. Basically, it depends on the stability of the spine, instability, as well as the discoligamentous injury, osteoligamentous injury, as well as the presence of the disc fragment. Suppose if your patient has redundant discs or the the disc prolapse, in that case, you may consider the anterior approach. You can do it by discectomy, and it is easily tolerated, and you can remove the end plate, and it is effective. How it is done? As you have shown here, we usually do it by using the 2 Caspar pin in a convergent manner. So you need to gradually distract so that there is a distraction occurs. In that case, you may also help the lamina spreader or prodix spreader. So what we actually do? We do actually pushing of the proximal fragment as well as the pulling of the distal fragment. Sometimes you need to rotation. That will actually disengage the facet and ultimately reduction is achieved. So whenever anterior reduction is achieved, advantage is that it is associated with less pain with a very higher union rate, and posterior alignment is very good with a very low infection rate. But sometimes it is not possible to reduce anteriorly. In that case, you have to do posterior. When it is, suppose there is a associated vertebral body fracture, or there is a rigid or ankylosed spine, or the spine is very osteoporotic, or your patient has, the dislocation is cervicothoracic junction. In that case, you have to consider posterior or combined. Posterior approach, actually, we are doing it by leveraging a curved instrument, and we are actually addressing the direct pathology. That's why it is biomechanically sound and stable. Sometimes you may need to do the combined approach. That means you have to do the anterior, posterior, posterior, anterior, or anterior, then posterior, again anterior. It depends on if suppose anterior reduction is failed, or there is a question of stability. Suppose the patient spine is very, the osteoporosis, or there is the ankylosing spondylosis. In that case, you have to need the combined procedure. And country like ours, there are some situations like the delayed presentation, it is very much difficult to reduce. The close reduction. In that case, you may need to open reduction. That means you need to the combined procedure. So sometimes if there is a floating lateral mask like scenario, so in that case, you have to do either 2-level SCDF or 2-level posterior fusion. So this is the summary of my presentation. So your patient, if you are trying to close reduction, suppose reduction is achieved, there is a disc herniation, and if it is a unilateral dislocation, you can do it by anterior discectomy. If it is a bilateral dislocation, in that case, you have to do both anterior and posterior. But remember, if there is no disc herniation, for unilateral dislocation, you can do SCDF. Bilateral dislocation, you can do posterior procedure because there is no disc herniation. But scenario, if the disc is, the facet is not reduced, or close reduction is not attempted due to some reason, suppose contraindicated, in that case, if your patient has disc herniation, for unilateral, same as anterior discectomy, for bilateral, both anterior discectomy and fusion. But if there is no disc herniation, so decision is again up to your choice. So finally, I would like to say that the optimum treatment strategy of cervical facet dislocation are still a matter of debate. So there is a still debate in, the close reduction, timing of close reduction, as well as the operation, approaches, etc., etc. So careful history, physical examination, along with advanced imaging modalities should be used to identify the type and extent of injury. And selection of appropriate treatment is based on the goals of providing mechanical stability to the column and neurological compression. And of course, airway close reduction should be attempted in a patient with neurological deficit as quickly as possible. And MRI should be obtained prior to any surgical intervention. That means whenever if you are going to plan any surgery, you need to MRI. And if there is a disc herniation is identified, of course, the anterior discectomy is preferred. Otherwise, you can choose whether anterior, posterior, or combined. And it shows that both the anterior and posterior approach result is almost equivalent. But in some scenario, like when there is a question of stability, where there is a chances of failure, you have to consider the posterior procedure or the combined procedure. So ultimately, decision is based on the exact pathology, facility expertise, and the infrastructure. Thank you all for patience.
Thank you very much, Dr. Jonayed. Let me see.
Please.
So no questions. Well, we have one question. Is the reduction maneuver same for unilateral versus bilateral facet dislocation?
Actually, the reduction maneuver for unilateral and bilateral, as I have already mentioned, that bilateral it is easier to reduce, and most of the cases, almost 100% cases, it is reduced. For unilateral cases, actually, it is very much difficult to reduce. In that case, you need to support if you are using the 2 Caspar pin and as well as the laminar spreader or protic spreader, whatever method. But in that case, you need to some rotation. Suppose you have to apply the pushing of the proximal fragment and pulling of the distal fragment. At the same time, you have to rotate the proximal fragment. So to disengage the the facet, that will help a little bit to disengagement of the facet joint dislocation.
Yeah, there's another comment by Dr. Vishal. If there is no neurology with unilateral facet subluxation, is surgery mandatory?
So
Yeah.
ideally, unilateral facet subluxation, though there is intact neurology, I would prefer to do surgery, because there are some literature, it is clearly shows that evidence that if it is not reduced or surgery is not done, though the patient is neurologically intact, but later on the instability may grow and ultimately it may causes the malalignment, and also that is associated with the neck pain. So to avoid the malalignment as well as to avoid the neck pain, surgery should be done very cautiously.
But do you attempt reduction for unilateral? And if it's reduced well, do you still go in for surgery?
So I will go for surgery. So again, it depends on the timing of presentation. So if it is presented within a very short time, maybe the 4 hours I can try. But if it is presented in the late, in that case, as there is chances of reduction is very less. So my preference will be go to surgery directly.
All right.
So-
Okay. Vijay?
Yeah,
Please.
nothing. How do you define failure of close reduction?
So actually it defines radiologically. If I see that in serial X-rays, if there are 3 lines of spine: anterior spinal lines, posterior spinal line, and spinolaminal line. If these lines are not coincide with the proximal and distal along with the whole axis C2 to C7, that means that it is not reduced. In the same time, if it is not reduced, there will still the presence of kyphosis is present. That is also regarded as the failure of reduction.
Additional questions from Dr. Vishal. During a weak reduction maneuver in ER in a patient with neurological deficit, do you not fear that this may further go inside and worsen the neurology? Similar for patients without neurology. Yeah.
Sorry.
Yeah. So
Please repeat the question. I cannot hear.
Yeah. So are you worried about this during the reduction, that this will cause further neurology or neurology in a patient without neurology when you do the reduction, the disc product?
Actually, I have already mentioned that there are literature suggested that theoretically discs may cause neurological deterioration, but as per literature evidence, it shows that chances of permanent deficit is only 0.92% and transient deficit is 1.7%. So if we do the awake reduction, in a coordinated patient, oil control patient, so patient is awake and patient is oil coordinated, in that case we can easily do it.
What is the maximum weight you are using before abandoning close reduction?
So it again depends on the type of the injury. So maximum weight that can be attained, it may be up to the 30 pound. In case of if you do it by slow process, or if you do it by rapid process, you can do it on 60 pound. It is possible. Remember, you have to very carefully observe whether there is distraction. If it is distracted more than 1 centimeter, you have to stop there. Or if you see that there is already is neurological deteriorating, so in that case you cannot continue furthermore. That is very much important. So one point is neurological deterioration, that is not so much common, but distraction I think is very important point. If you see that it is already distracted more than 1 centimeter, in that case you cannot continue further.
Maybe one last question from Dr. Dastagir. He asks, when should we avoid skull tongue traction or close reduction? In what situation should we avoid it?
So number one is if you are suspecting there is a local site infection, you cannot do it. And another thing is, suppose the spine is very osteoporotic. In that case, you cannot do it. And another important is the patient, I mean the condition of the patient. If you think that patient is not well, I mean the patient will not follow your instruction. Patient is not, I mean the non-cooperative, or patient is unconscious, patient is in head injury. In that case, you cannot do it, that wrong traction. That is very much important.
All right, thank you very much. Thank you very much for the lecture and all the Q&A. So maybe we move on to the next presenter.
Thank you. Thank you.
Dr. Brian will be presenting on odontoid fractures. Dr. Brian. You're muted.
Yeah, I already prepared the slide. Jada, can you start playing?
I think there's no sound from the slide. Maybe you can on the sound.
Yeah, we're still not able to hear anything.
Jennifer, do we have the author here directly? We can have present him live. Vijay, can we have the talk live also?
Yes, you can.
Yeah, maybe Dr. Brian, you play from your computer? Maybe.
Yeah, okay. Yeah, okay. Just give me a minute. Why don't you change the speaker first? Let me open my computer.
Yeah, maybe we can have the speaker meanwhile.
Yeah. Okay.
So maybe you go on to the next speaker.
Yeah.
So
okay,
sorry about that, Dr. Brian.
No problem.
Yeah, Dr. Srivastava, you can take over.
Yeah. So I will share my slide.
So while you share your slides, Dr. Srivastava, you have wide experience on chronic neglected facet dislocations.
Yeah.
We compliment your articles. We have seen, read, and learned from them.
Yes.
So while this comes up, I'll just like to bring out the fact that on 29 September, we have second advanced webinar series on spinal endoscopic surgery. I urge and request all the delegates who are here to join for the webinar on 29 September, Sunday, same time on spine endoscopy. And I'm sure the August faculty members are going to cherish the knowledge, experience that they have and share with you all. Over to you, Dr. Srivastava.
Yeah, thank you very much, Dr. Vishal, and the whole of the APSS for this opportunity. Actually, regarding the previous lecture, which you asked the question, actually, we have even reduced the 3 to 4 weeks old dislocation also. The good point is that the patient is awake and you can monitor clinically. And it can be done very nicely. Regarding this unifacetal, so if unifacetal is too late, then it is difficult to reduce it. But I would always prefer to operate and reduce it, because you should not leave these people, because the biomechanics is at fault, and any time any jerk can lead to problem. So it is better to align the column. It is vital. the MRI is important to see the status of the disc, whether it is going to go inside the canal. In that case, it is better to previously first go ahead and do the discectomy. In that time, at that time also, you can try to reduce it after doing the discectomy. And many a times, just anterior procedure can be fruitful and you can achieve the reduction. Whenever you are doing only anterior, always contour the plate, and because you are putting the plate on the buttress surface, it is not the tensile surface, and one should avoid early flexion. So that was the answer for that question. Now I will be now talking about management of Hangman's fracture. Now, proper actually management would need to identify the fracture and its different component of injury, the mechanism of injury and the status of displacement, any other associated injury adjacent to C2, C3 complex. I'll be showing the case later on. This is a very good article. I think everyone should go through it. And this was published in European Spine Journal in 2003. Now, this name has importance. Earlier, people used to do this judicial hanging for capital punishment, and there used to be significant, hyperextension and distraction injury. Yeah, I'm just trying to move fast. Yeah. So there were two ways of doing this punishment, and one type there used to be submental knot, and another type there used to be suboral knot. And if you see this submental knot used to cause acute extension and distraction, while this suboral knot used to cause acute flexion and distraction. Remember, in hanging, usually there is a distraction, and that causes significant injury to the spinal cord. Now, there are other mechanisms of injury where the patient can sustain trauma during the road traffic accident, falling from the height, or high contact sport. So you must know what is the cause of in that case, because whatever displacement is there due to the specific mechanism of injury, and if you wish to realign it, it is better to undo that, and then it will be easier for you to attain the reduction. What is the definition which describes the pathology? So it is basically a traumatic spondylolysis and or listhesis of axis vertebra due to fracture of bilateral pars interarticularis, or any combination of fracture of posterior element, either it may be pedicle, lamina, facet, and may be associated with the C2, C3 disc with different degree of displacement. Now, why I have mentioned such a long definition? Actually, if you see, there are many classifications which have been given to this entity, but this definition actually includes each and every part of those classifications. So don't only concentrate on the bony injury, the soft tissue injury is extremely important. Now, once you identify this fracture, you must try to find out what is the type of and mechanism of injury. And there are different classifications based on the status of the fracture, displacement, and mechanism. Now, this was the first classification which was given by Effendi. And basically, it is a very simple classification. Everybody should remember it. Very easy to even practice also. Only three types, 1, 2, 3. As we, try to memorize the different sites fracture in the body. So one is whether there is a fracture but no displacement or less than 3 millimeter displacement. The two, there is a displacement. And third, there is a subluxation or dislocation of posterior facet joint. Extremely simple. So fracture, no displacement. Second is with displacement, and there is a fracture dislocation. So this is very simple. And this diagram has been very nicely actually given by, the JP Brother and Medical Publications Private Limited. Actually, they have mentioned in the fracture chapter of the fracture of this, and which is actually ASSI monogram, is ASSI book. You can go through this. The second is the Levine and Edward classification, and this was given and added the angulation and displacement. If you see this, what he has done, he has added 2A type subtype also. So there type 1, there is less than 3 millimeter of translation, no angulation, and the mode of injury is hyperextension plus axial loading. Type 2 is more than 3 millimeter translation, minimal angulation, and here the mechanism of injury is hyperextension and then flexion. So there is a rebound flexion. And type 2A he has mentioned when there is a angulation. There is an angulation, and this is because of the flexion and distraction. So you know it moves apart. And of course, the type 3 is where there is a subluxation and associated dislocation of the facet joint. Now, to summarize the two classifications together, you can see the extra one in this Levin and Edward classification is 2A here. Now, the third is the Francis classification he gave in 1981. And actually, he added the component of, different degree of angulation. So basically 3 types where the displacement is more than less than 3.5, another more than 3.5, and if there is a associated disc injury, that becomes type 5. So in this 3.5, when it is less than, if the angulation is less than 11, he tells it is 1, more than 11, 2, 3. It is according to the severity, less than 3 and more than 11 degree becomes the 4. So they are the different way of describing it according to the severity of displacement. Now, Jostling classification, he was the first one to stress on the importance of MRI. If you see these injuries, fracture, it is okay, but there is the associated soft tissue injury that is rather more important because fracture, they unite. And this soft tissue injury, it doesn't unite so readily. If it is a pure soft tissue injury, then you will always have an issue whether it goes into improper healing. So he has described in 4 types. Type 1, there is a intact anterior longitudinal ligament. And in fact, he has described the treatment also. Just put the patient on halo. Type 2, intact anterior longitudinal ligament, but ruptured disc. But ruptured disc, again, halo. Type 3, ruptured anterior longitudinal ligament, ruptured disc. And here he has described that here one should try to fix it surgically. This is important because here there is a rupture of anterior longitudinal ligament also. And type 4, there is a facet dislocation and there may be locked facet. So you have to open here posteriorly. So I think this is pretty simple, and he has given the importance of soft tissue injury. Now, this surgeon has given added classification, and he has given the importance that there may be atypical Hangman fracture also. And he has published it, and you can go through it. 2015, he has published very nicely. And what is it? Basically, he has given these 3 varieties. The last one is the typical Hangman. So what he is trying to say that the fracture, it might be in the body part and not classically in the pars, which may or may not leave the ring of the axis intact. Okay. So actually, this is important because suppose the fracture in the anterior part of the body, and there is a intact, there is a rupture of the ligament also. This may lead to problem and neural structural damage. So here there is one type which is coronal fracture in the body, then unilateral oblique body fracture with contralateral pars fracture, and 2B becomes when there is a fracture on another side where there is a lamina fracture. So 3 types is described: type 1, type 2A, and type 2B. So this has added this type of atypical fracture. And in fact, he has meta-analyzed all these papers and even the treatment thing also. And he has stressed that one has to be judiciously planning the treatment. It is extremely important on the outcome. Now, this is the most recent one, AO classification, which was actually given in 2022. And basically 3 types of fracture for the upper cervical, of where in first type there is a fracture of the occipitocondyle and there is a CV junction injury. The second type, C1 ring and C1 C2 joint. And third type is C2 and C2-3 joint. So basically, if you see here, we are concerned today for Hangman fracture. So it is the type 3 one, whether C2 and C2-3 joint might be involved. It may be type 1, B, and C. And this is also classically as per other type of classification we have. Here, there is just bone injury, no soft tissue injury. Here, there is, in type B, there is a soft tissue injury. That becomes very, very important. And there may be associated fracture or no fracture. And type 3, again, the same thing, the posterior element might be ruptured, and there is a translation and displacement. So you have seen even the thoracic lumbar fracture, what the AO has given. So it is basically the displacement, subluxation, dislocations, wide displacement, it becomes type 3. And also they have added the injury modifier. So they have this modifier, they have given a 4 type, M1, M2, M3, and 4, where in M1, there is a high risk of non-union without operative management. M2, injury at higher risk of instability, with the high risk of instability. 3 is patient-specific characteristic which may affect management. This is very important. Mentally retarded and he's not able to follow the command. Even though if you can treat with the rigid cervical collar, you cannot treat these patients like that, and there may be problems. So sometimes the because of the specific scenario, the management changes. And M4, any vascular injury which may affect the management. Now, neurological skills, again, they have also included that. N0 means no neurological deficit. N1, if a neurological injury resolves. 2 is continued regular symptoms, and 3 is the incomplete spinal cord injury, and 4 is the complete spinal cord. So he has actually practically, they have included everything which they have done in other classifications also. Now, there should be special consideration in pediatric age group. What is important? We must be aware that there are 6 primary centers and there are synchondrosis joints. Why it is important to know? If you see these joint area, you should not think that there is a fracture, because this plate is open and one should not consider there is a fracture. Moreover, in pediatric patients, there is a significant ligamentous laxity. And if you are planning to operate this patient, don't expose the spine unnecessarily. Otherwise, there may be autofusion. Try to restrict the area so that patient preserves the mobility later on. Okay. Now, what is the recommended management? Now, we have seen all these things. What is important for FND 1, 2, Levine 1, Johnson 1, conservative treatment can be tried, rigid collar and halo can be applied. Now, this halo has gone into this review. Mainly if the age is slightly higher, these patients have problem. And many a time maintenance of halo is sometimes difficult. Now, if you see, you have a large series where the patients have been treated with halo. But nowadays, people are actually trying to, intervene. And sometimes they have also commented that rigid collar is better than halo. The Levine 2 and Johnston 2 surgery is actually indicated, where anteriorly you can do ACDF or posterior C2, C3 fixation. Consider combined if there is fracture which is atypical. Levine 2A and Johnston 3 surgery is recommended, anterior or posterior, but combined if non-optimal post-op alignment or atypical fracture. Why it is this one is very, very important. Suppose you have seen and you have operated the patient, but at that area you are finding that the alignment, always try to achieve the lordosis. This is extremely important. Whatever surgery you have done, you tell the patient to keep the neck in extension. This is extremely important. Even consciously, he can keep in extension, because whenever we are putting plate anterior, it is just a buttress plate. It doesn't have anything which the tensile surface has. So one should guard the patient for this fact. And Johnston 4 or Levine 3, preference is combined anterior posterior with possible C1 liberation screw. What is C1 liberation screw? If you find it is very unstable, you try to extend your fixation to C1, and at later date, once fusion has occurred, you can cut the rod and you can take out the C1 screw. So this is C1 liberation screw. Now I will show you just 3 types of these cases. This male, he presented with fall of object on his head at construction site. You can see here, there is a fracture of the pars in that area. He had significant pain, but no neurological deficit. Now, if you see this, now here, if you see the central cut, you feel everything is fine. But if you go laterally, so this is very, very important because the joint are there in the paramedian cut. You will not get in the center. There is a fracture here. And also just below that, there is some discal, intensity changing. You can see here also, there is some intensity changing. And you can see this is the CT of the patient with the fracture. Here also you can see the this para central cut. You can see nicely the part. So whenever you are asking for the CT, you should ask for these views. These are very, very important. And even you can see what is the alignment of this facet joint. Okay, and that guides you, treatment modality. So we have just fixed it, both, and then we did well. Now, this is another patient, 30 years old male, gardener by occupation. He fall from a tree, 15 feet height. And he presented to us very late, 2 months back, took medication from the local practitioner. And when he came, this was the situation. You can see. Even if you see, there are changes in the fracture surface. It has become almost round. So pain was the main symptom, which due course of time had decreased also. But he started complaining of tightness in the limb. So he had just starting off the myelopathic sign. There was a mild tenderness, no motor deficit, and the reflexes were brisk. Now, supervised dynamic, X-ray was taken, and to see whether any mobility, hardly there is any mobility in this case. C2, C3 disc space was almost obliterated, and fracture ends has become smooth. So you can see that this is an old fracture. So this we say is a neglected Hangman fracture. Now, if you see here and try to see this, observe the disc here, you can see it is almost lying in the canal, and no disc space at all. It is obliterated. You can see here also there is a fracture in the articular part, and this was the CT. And it is better to see all the CT plates and try to read the fracture, what type of fracture it is. Usually I write my OT notes and then draw the diagram. So in this case, what we did, I went first anterior. I took out the disc, then turned the patient and did posterior fixation, and return the patient and did plating. So in that case, what happens? Your alignment becomes better, and you are able to achieve a nice reduction and fusion also, because you are going to put graft here also and posteriorly also. So here I usually put bone graft. Now you can see this is the CT. Have achieved the union. Now here also in this central cut, you can see the screw going into the arch area. Now, this is the last case I'm going to present. Now, this is like an atypical one. 35 years old civil engineer. Actually, he was cousin brother of my then dean. Came to emergency department with a soft cervical collar and complained of pain in cervical region. There was a contused abrasion on his forehead, and there was a history of fall from staircase. And forehead got the impact of trauma. So this was the picture. So here what has happened, there was a fracture of all these posterior elements, C1, C2, C3, and there was a spondyloptosis. But he was neurologically intact. So all these posterior element fracture has given in the space. So the cord was not damaged at all. It has opened the door for the safety. Okay? And you can see here, this is the CT of that patient. You can see a wide space here. All posterior elements are behind Hangman. There is a spondyloptosis of C3 over C4. So in one cut, you can see both the body in axial cut. And this was the picture. You can see here, part of the disc here. Yeah. So this was the injury. Now plan. Now there are different papers which have been published, like regarding this spondylolisthesis, apply the halo, or you go for anterior discectomy and fusion with internal fixation for unstable fragment, Hangman fracture. Now, how to reduce it? We did not have neuro monitor. This is a 20 years back case which I had operated. What should be the level of fixation? The displaced fracture of posterior element of C1, C2, C3. So all these are fracture. So stable fixation will be at least you span the fixation from occiput to C4. So we had a detailed discussion with the anesthetist, and they agreed for the awake intubation. So the fiber optic nasotracheal intubation was done. I have purposely kept this photo in that way. I wanted to cover the whole face, but you see he's awake. He is awake. And then we did gentle traction and slight ascent. You can see he has fallen very nicely. It is aligned very nicely. And I did first anterior plating. And I saw that all the posterior elements are coming very close by. So we did not do any, posterior procedure. And patient was explained that he is supposed to keep his neck always into extension. He was not allowed to go outside his home for some time. And he followed it religiously because he was an educated engineer. So he could, get that what is important of all these instructions which is being given to him. Only indoor sedentary activity for 3 weeks, Philadelphia collar in extension for 3 months, 2 years follow-up. He has healed very nicely. And you can see what was the situation earlier. This was the situation 2 years follow-up. And we documented with the CT, it is nicely fused. That was the picture earlier. And if you see the axial cut, it has united nicely. This was the picture earlier. So everything went into place. So I'll conclude the Hangman's fracture is a tricky fracture. So its management, for its proper management, it is extremely vital to identify the fracture and its different component of injury, especially search for any associated soft tissue injury. This is extremely important because, you can get away with the bony injury, ultimately it unites or malunites. But soft tissue injury, if it doesn't unite, then always your spine will be at risk. Go through the images and try to know the mode and mechanism of injury, and then you plan the treatment, achieve a sound biomechanical alignment, and assure sound stability with bony fusion. This should provide a long-lasting, fruitful outcome. I thank you very much for your attention. Thanks a lot. I will share this.
Thank you, Dr.
Yeah.
Srivastava. There's a question in chat. Is the management different for typical and atypical Hangman fracture?
No. If you see, just I will close this box. See, it is almost same. The fracture site posteriorly might differ. In one, it might be there in the body, oblique fracture in the body, and one side it may be just in the pars. So in that case, when you are planning fixation, you should see that you hold the distal fragment also. That is one. Sometimes there is a high risk if suppose that whole loose piece, posterior piece, it goes back, then there may be injury to spinal cord. So one has to be careful about that. And there is no significant difference in the management. Only you should be able to identify and don't miss the atypical injury in that area. That is the only thing which is important. One should be aware about this entity.
Okay. And do you always look at integrity of transverse ligament in?
Yes. Reading the MRI is extremely important. And when in the proper cut, you will able to know whether the alar ligament, apical ligament is ruptured or not. Only you have to sit with the radiologist if you are specifically you wish to know that, and try to sit that gantry and try to have a particular cut there, and then you will be able to definitely know it. Because if dense is unstable, then there will be a problem.
So any other question from other panelists?
I think Dr. Vishal asked also, do we always do a CT angiogram in all cases with Hangman to evaluate the vertebral artery injury?
Ideally, yes. It is not only Hangman. Even in cervical spine, one should do ideal. That is the ideal situation. But what is the trick? When you do MRI, always see those small foramina both the side, right and left. So in one side, you will find that space, another side, it will be, hyper intense, maybe the lumen is blocked. Okay, and it is edema in that area. So then you start suspecting. Okay, and sometimes this goes undiagnosed because patient is surviving on one vertebral artery. So this is extremely important, but routine cases we don't do it. What is the guideline? If patient has congenital anomaly, then you must definitely do. Otherwise, all the cases we don't do it.
Yeah, Dr. Dastagir asks, any tips for anterior approach into getting the C2-3 space?
Yeah. So you should try to have extension. Your mandible usually comes in the way if you're not got little extension, and go to that area. Try to have a little higher transverse incision. Okay, expose that area properly, because your plate is going to go there in C2 body and C3, and you wish to take out all of this. More so, you should have fine instrument to just try to put your probe inside and take out the disc. Okay, your bed preparation is also extremely important, and there you should take out the soft tissue and cartilage and put a bone graft nicely. I usually put bone graft, but one can choose even case. This is not a problem. But basically, approach is important. Position of the cervical spine is important. And, your technique of removing all the soft tissue. Always try to contour the plate so that after fixation, the cervical spine, upper cervical spine should be in extension. If you wish to do only anterior, put a rigid collar and tell the patient to always knowingly keep the neck in extension. It is a matter of few weeks just. Then you can avoid any posterior surgery.
Yeah, thank you. One more question from Dato Kwan. If there is no C2-3 disc injury on MRI, the C2 pass or pedicle screw alone is adequate?
Adequate. It is adequate. Even the collar is adequate. If there is a just fracture of the pars, you need not operate that patient. If he is able to follow the command, you just put the collar into extension. All these patients, they unite.
Okay, maybe I want to ask one question. There are so many classifications being described. For us, which do you recommend us to use? There's so many, it's a bit complex to use all.
So better to follow the simple one. Okay, the wind one, and add that soft tissue component also in your decision making. So fracture, are there, and there are soft tissue injury also. So simple is FND and Levine Edward classification to follow, and then see whether associated soft tissue injury or not. And I think that makes the your life very simple. And most of the time, 99.9, you will be able to make your proper plan. There should not be any problem. C2 pass fracture also. So, whenever you are trying to pass the screw, the one tip I would like to give that one side you pass the K wire, another side pass the K wire. Then you take out one side K wire and then pass the screw on that side. Because if you don't, once you tighten the thing, everything starts rotating and it might get displaced. So it is better to have a temporary fixation first and then convert one by.
Yeah, okay. Just additional question to the answer you have answered. If you choose to to undertake a conservative treatment for just the fracture alone without this injury, how long should collar be worn?
Definitely 6 to 8 weeks.
Okay, thank you very much. I think we should proceed to the next speaker. Yeah,
there's just one audience question also. Just one.
Oh, okay. All right. Okay. Audience asks how to plate C2-3. Any approach related to this insight? I think it's
there is a standard approach for ACDF. You make the incision slightly higher up, and additional instrument you must have in your trolley is deverse retractor, not very wide one. You keep a small deverse retractor, okay? And that takes care of the higher structure, and your whole view is very, very clear. So in your set, always ask for deverse retractor, and everything is very clear and very, you don't have any obstacle there. Okay, so incision higher up, sometime if if required and you are struggling to reach there, the superior thyroid artery sometimes needs to be ligated. Okay,
Yeah.
so that is one thing. It is a rare situation. Yeah, sure.
Dr. Vishal?
Yeah, so basically, I have been doing Hangman's fracture anteriorly for quite some years. I think this approach related thing, the two things that are absolutely mandatory that everyone who approaches the C2-3 disc space and pays serious attention to this is, one is in the digastric triangle, it's a high incision. It comes just under the submandibular angle, it's just underneath it. And so the submandibular gland or parotid gland, sometimes they are hypertrophied, particularly in males who are chewing gutka, particularly in our setting, or alcoholics where there is a parotid swelling there, which is like a large gland. So if you go slightly high up, the gland may just come and your cautery can actually burn it. And there are multiple reports of leak after the surgery, and these are all saliva that comes from these glands. So one must pay attention not only to the glandular structures, but also the submandibular duct, which just runs and goes and opens in the molar teeth area. So one thing. The second, deeper in the digastric triangle, is the hypoglossal nerve. So if you retract it too hard, particularly in patients with short neck where you're not hyperextended the neck, the chances of you injuring the hypoglossal nerve during exposure is very high, resulting into partial paralysis of the tongue and voice change. So these two things one must pay attention. And if you're not confident of doing it self, it is absolutely okay to have an ENT access surgeon. They give you a wonderful access to the C2-3 joint area and also expose the tip of the odontoid, because sometimes your plate has to reach all the way to the odontoid to get a screw in there. So I think these two tips one must remember when approaching the C2-3 joint.
I will add one more thing, Vishal. So the deverse retractor, which I told you, it is very handy and you will not have these problems. For all my anterior approaches, even the ACDF, I used a wet gauze piece. On that only the retractor is there, so it will never damage that. And with the help of deverse, the exposure is extremely important, because you should not compromise on fixation. If your exposure is not good, you will find that your plate is screw is going somewhere, your plate is off the side, it is one side, so the purchase will be difficult. Another, one must understand the shape of the C2. It goes down like this. Okay, so it should not be just your tip of the downward projection of the body. You should go in the real body area, then only you will have a bicortical screw fixation. So these are the small points, but it is very important. First is exposure. Good exposure is required, and if you follow all these things, there will not be any problem. Your dever will retract all these things very nicely. Keep dever in your set, and then follow the biomechanism. This is important.
Another thing, one should not try to push the C2 too hard behind, because sometimes the C2 can actually, it's a acute fracture. After discectomy, the C2, which is like a loose body, there is a pars fracture, the C2 is loose there, and you have hyperextended the neck. So if you push it, we have had situations where the whole C2 gets pushed behind and a retrolisthesis can happen, compromising the cord space there. So pushing the C2 too much is not really a good idea. And one must also remember that the normal plates that we use at C5, 6 don't come handy in the odontoid. Remember, odontoid is like a triangle, and to keep the plate which is going up, you need to have a narrow profile plate. You have to have from medial-laterally, the plate should be really narrow, and try to have full inventory of narrow plates. Even mandibular plates come very, very handy sometimes.
Yeah, thank you very much for the Q&A and discussion. I think we will move on to the next speaker. The next speaker will be Dr. Brian, who will be presenting on C2 odontoid fracture.
Yeah, give me a minute. I'm still trying a technical error.
Okay. Yeah, maybe I think there's questions from audience, maybe to Dr. Srivastava. You have shown C3 for spondyloloptosis. How would you reduce it Yeah. Can you give some tips? Yeah. You're muted. You're muted.
Yes. So actually, in fact, I told all the step we took, we discussed with the anesthetist, awake fiber optic intubation and awake gentle traction, and it came into place. Okay. So since it was a very fresh fracture and just gentle traction, everything got reduced very nicely. I showed you the Siam picture also. And then there was a question. We did it entirely. The fixation was good, and we thought we will just spare and will not do any posterior fixation because the fixation would have been very long and without any problem. So this reduction is very important. And if you have neuro monitor, this will be definitely be helpful to you, and you will be your heart rate will be in controlled manner. So you will not be worried about anything happens. You will come to know immediately. So I think you should try reduction, and it comes very nicely, very nicely.
Yeah.
Because it's
Yeah.
a fresh
Just some question.
Yeah.
Additional question.
Yeah.
What if you cannot reduce it? What would you do?
Then
in that situation, yeah.
Yeah. So you will open that area, release that whole thing. Okay. Even after releasing everything, you are not able to gain the thing. Then the ultimate thing is the corpectomy. You have to do the corpectomy and then align it. So that is the situation which can, even the neglected, dislocation, people have treated with the corpectomy of one thing which is overlapping and then align the column.
Okay. Thank you very much. Dr. Brian, are you okay?
Let me try. Yeah.
Yeah.
Good afternoon, everyone. I'm from Malaysia. My name is Brian Teo, and we're talking about management of odontoid fracture. The arterial blood supply to the odontoid process forms a constant pattern of 3 groups of blood vessels from 2 sources: the posterior blood vessel from the vertebral artery and the cleft perforating vessel from the carotid artery. Thus, there is a watershed area at the base of the odontoid fracture. Sorry, at the base of the odontoid.
We can't hear you, Dr. Brian. Yeah, more. Please increase the volume fully.
Life-threatening neurological deficits. And the treatment aim is to re-establish the stability of the atlanto-axial complex. Treatment usually begins with a detailed history, such as a young patient with high velocity trauma or a elderly patient that just fall. A physical examination usually reveals that there is pain sub-occipital, and also in some certain cases there are patients presented with a neurological deficit. Although most of the time we don't see them having these problems. Conventional X-ray in 2 planes, cervical and open mouth view is mandatory. CT scan should reveal a better fracture pattern, and MRI would be good to look at the ligamental injury. This is a lateral view of X-ray showing that in the picture A, it's a base of odontoid fracture with distal part translate posteriorly, and the picture B showing that there's a base of odontoid fracture without any displacement. This is the open mouth view of X-ray, which you can see that there is a fracture at the base of the odontoid. With the help of a CT scan, it usually gives us a better idea of the fracture pattern. Thus, it actually helps us in deciding what type of treatment, either conservative or operative, and either it is from anterior or posterior approach. Classically, odontoid fracture, we will follow Anderson and Alonso classification. With type 1, which is the tip of odontoid fracture, type 2 is the base of odontoid fracture with watershed area, and also type 3, which the fracture has involved the body of C2. Raoul classification is an extension of type 2 Anderson classification, with type 2A is a transverse fracture, type 2B is an anterior superior to posterior inferior transverse fracture, type 2C is anterior inferior to posterior superior fracture. Current practice of odontoid fracture includes 6 possible options. There is collar and hollow fixator, anterior odontoid screw fixation, anterior transarticular C1 C2 stabilization, posterior transarticular C1 C2 stabilization and fusion, posterior instrumentation, which is Harm's technique, and also posterior occipital cervical stabilization and fusion. The more common practice now with operation is anterior odontoid screw fixation or Harm's technique. Treatment of collar and hollow fixator still remain controversial because study shows that soft collar provide no stabilizing function, and hollow fixator actually aggravate mortality and mobility in terms of pin thread infection and also movement restriction. And the study shows that the union rate for conservative treatment for odontoid fracture is only about 40% compared to operative treatment, which is as high as 70%. Anterior odontoid screw fixation remains the most commonly performed surgery for odontoid fracture because it allows a shorter hospital stay and a faster recovery. Usually, this is the anterior approach with either one or two screw. It is good for young patients with good bone quality without any modifiers. In the next slides, I will discuss what is a modifier. The screw typically used is a 4.5 mm or 3.5 mm diameter. Depends on the size of the odontoid, and it must be partially threaded to allow good compression. You also need a 2 C-arm placed epi and lateral, and you need a Mayfield clamp as well. Personal experience, I think that it is very difficult to perform for patients with short neck and obese, because the obese patient with large chest might cause a trajectory difficulty when we insert the screw, or in the first place insert the guide wire. Before performing the anterior approach, one must check with the modifier. If the patient is osteoporosis or with a severe ossification of the ala ligament, fused anterior ala atlas ring to the tip of the odontoid, reverse fracture line, not reducible fracture, small cauda bone fragment, inappropriate body habitus as I just discussed, or severe kyphosis, one should consider a posterior approach rather than an anterior approach. Next, describe anterior approach is anterior transarticular C1 C2 stabilization. It is to be considered in elderly patients if posterior approach is impossible, and it is regularly combined with odontoid screw. But personally, I think this approach is difficult because of the limitation of the surgical field. At least I have never performed this surgery before. Posterior transarticular C1 C2 stabilization and fusion is also described in the treatment for odontoid fracture. And the crucial step is to reduce the fracture before inserting the screw and maintain the correct reduction. One typically needs to watch out for vertebral artery furration, and so pre-operative CT angio is mandatory. I think posterior instrumentation Harm's technique is more commonly performed now, although I don't have data in hand. It's because most of the spine surgeons are familiar with C1 lateral mass screw and also C2 pedicle screw. So compared to the previous approach, I think this is easier for most of us now. Typically, posterior occipital cervical stabilization and fusion is for patients with a stiff spine, such as ankylosing spondylitis and diffuse idiopathic skeletal hyperostosis. This patient is an 80 years old lady with a type 2C fracture, which happened when she had a fall at home. She came to me with suboccipital pain without any neurological deficit. Looking at the fracture pattern, I initially wanted to perform a C1, C2 instrumentation without fusion, but the CT angio shows that there is abnormality, so I decided to do a occipital to C3 instrumentation without fusion. On the right is a CT scan taken before the screw removal to make sure that union taken place. In this CT scan, union fusion clearly taken place with minimal displacement and with good canal diameter. On your left side is an X-ray taken after the screw is removed. This patient took about 3 months to resume her normal head rotation and flexion extension. This is a treatment algorithm suggested by NIH. Anderson type 1 is best to treat cervical orthosis. Type 2 or 3 fracture without any modifier, it is best to treat odontoid screw fixation. However, with the presence of modifier, C1, C2 stabilization is recommended. Either anterior or posterior approach, I think mostly also depends on the surgeon's experience, technique, and their own preference. Thank you very much. I hope.
Thank you, Dr. Brian. So let me see, is there any questions from... Okay, there's no question. Maybe I will start off with the first question. You mentioned that you're not, Halo is come with certain morbidity. So in any situation, would you still use Halo, or it's either collar or surgical fixation?
You can unshare the screen if possible.
He has to unmute. I don't know
Yeah,
whether he has...
okay, all right. Can you hear me?
Yeah.
Yes.
Yeah, okay.
Yeah.
I have not performed a halo vest for many years because of history with bad experience with a pintrain infection, and also for the patient to have an idea of putting an external orthosis with your pin in the skull. I think a lot of patients will have just rejected the idea and they rather use a hard collar if they have to, and they're not suitable for operation. Otherwise, I have not using that for many years.
There's a question in chat. Odontoid fracture with comminution, does your management change or it remains the same?
If it's a comminuted fracture, I will still use a posterior approach, C1, C2, fusion or without fusion. Then we will look at the CT scan after 6 months. Yeah. Now, definitely it will not go to anterior because it's not possible to hold the fracture. Yeah, so I think posterior is a logical choice.
Okay. I think Dr. Vishal also another question. How do we evaluate a transverse ligament injury in a patient with odontoid fracture? And if you found one, does the management change?
If there is a transverse ligament injury, I think the best modality is to use the MRI to assess the ligament. Usually you will see some edematous changes around the area. If that is the case, I will do a fusion, definitely do a fusion for this patient, explaining why we do it. And of course, there is this disability of having this lateral rotation, which patient have to understand. Yeah, otherwise, I will not perform odontoid screw fixation for this type of patient.
Yeah, so you would avoid odontoid screw in suspicious ligament injury.
Yeah.
So I think Dr. Dastagir have asked is asking any tips for close reduction of a displaced odontoid fracture.
Okay. If you are talking about during the surgery, when you want to reduce before you perform the screw fixation, for anterior wise, usually it's for this anterior screw fixation. What you do is you normally put the Mayfield clamp, right, if patient in supine position. So what we do is, if we cannot reduce, right, by positioning the patient head, we will ask a person in the OT room, right, to wear an eye gown, to put his thumb, right, at the base of the skull, to hold it and shoot X-ray and see whether it's reduced or not. Then if it's reduced, then he will have to be there for quite some time until we finish the operation. Yeah, otherwise, I don't think there's any other way to do it. Yeah, sometimes when you fail,
there is another trick. There is another trick. Trick is that you, in your sponge holder, take a gauze piece, folded gauze piece, and in the mouth you press it. Go to that area and press it, and it will be easier to maintain.
I see.
Yeah. So in the mouth, put that folded gauze piece in the sponge holder. Go to that area, and under C-arm, it can be managed to be aligned, and then you progress the screw.
Would that interfere with the intubation?
No. Patient has been already intubated. So in that case, when it is otherwise, before in the ward also, if you had given text and it is not coming aligned, or you are finding that the dens has gone into extension, so this is the way one should do. So you can ask for the nasotracheal intubation. There is another way out.
Okay, all right.
Keep the mouth free. Keep the mouth free.
You usually press over here.
Yeah. Yes.
Press over here. Yeah.
Okay, there are other questions like, would you like to touch upon conservative management of odontoid fracture and what age group? Is surgery needed for everyone? That is the question.
Like I said, if you have a type 2 fracture, type 2 fracture is the watershed area, you know that there's a very high chance of non-union. If any time surgery is possible, then I would offer patient surgery. But of course, in the study also says that as long, sometimes when patients have this fibrous union, where they fuse without any bad translation, it is still possible to treat conservatively, provided the fibrous union without a lot of displacement with a canal stenosis. Otherwise, yes, if your patient refuse or you have no facilities to perform the surgery, you can still treat conservatively. With a fibrous union.
Other questions from the audience. After how much time do you remove the C0, C3, C4 fixation for odontoid fracture? Or do you remove it at all or keep it there?
I remove this particular patient that I just showed you. I remove exactly in 1 year time, 12 months. I'm sure you can remove it earlier as long as a CT scan shows that there is a union. Yeah, but this patient typically I remove around 12 months.
Yeah. Can you keep it there, or is it recommended to?
I did not fuse this one C1 to C2. So I suppose eventually this fixation will fail or the screw loosening. So, and we already discussed about this option of removing the instrument before the surgery. Yeah. So and then there's a lot of discomfort with this type of construct. Yeah. And so I would remove it whenever it's possible, because you're talking about limitation in flexion extension and rotation. I think it's best to remove.
Okay. Another question from the audience. Do you use any bone graft when you do a Goel's or a Harm's fusion technique?
Like I said, if for harms technique depends on the patient, like you say, with soft tissue injury, or it's a very old patient, yes, normally I will do a fusion. If it's a young patient, I won't do fusion. Yeah.
Yeah, but do you use bone graft, or what bone graft do you use
Oh,
for this fusion?
I normally burr the C1 posterior arch and C2 lamina. Then I'll put some DBM around it if patient is can afford. Otherwise, I will just use the iliac crest. But for now, I have not been using iliac crest for like 10 years, 15 years.
I think with constraints of time, we can move on to the case discussion.
Yeah. Okay. Maybe
One last
how many?
question.
Yeah,
You-
one last question. Maybe from Dato. Maybe Dr. Vijay, you want to ask the. Let me see.
No.
Oh, okay. One from the audience. From the audience.
Yeah.
Yeah, this one. Any tips for the C2 pedicle fixation? Yeah.
Any tips of C2 pedicle fixation? I think C2 is relatively simple compared to C1. When you do a C1 instrumentation, the idea is to identify the medial wall of the pedicle by using McDonald's or Watson chain, right? And someone have to hold the Watson chain around just at the medial part of the pedicle, and then you will drill as normal and using an X-ray to guide you for the direction. Whereas I think the more challenging one is actually the C1 lateral screw. As we described, there are many techniques of inserting the screw, which I think the most important thing is to get a clear view between the junction of the lateramus and the inferior wall of a posterior arch. You have to burr till you get the cortex, till you clear the cortex. And when you drill, make sure that 2% protect the medial and lateral soft tissue. And every time you drill, like for about 2-3 millimeter, just make sure you do an X-ray to make sure that it's not displaced or it's not too superior or too inferior. Yeah, I think C1 is more challenging than compared to C2 pedicle.
Right. Thank you very much, Dr. Brian. Maybe I pass over to Dr. Vijay to introduce the next speaker.
Yeah. So Dr. Dastagir from Bangladesh will be presenting on subaxial cervical facet dislocation. Dr. Dastagir.
Yes. Good afternoon, everyone. I'm going to present a case, and I invite all of you to participate in case discussion. A 45 years old male, he's a construction worker in occupation, history of fall from height, and now presents with after 3 days, referred from a primary center to a tertiary center. He presents with neck pain and weakness of upper limb and both lower limb. On examination, his neck movement was painful and restricted in all directions. During in emergency department, his upper limb sensory intake, his motor of the upper limb all are 4/5, and lower limb sensory intake and motor examination, there is a 4/5 in all group of muscles. So at first we have done the X-ray of the APN lateral view. So I asked all of you that to come and discuss and start with my case. Can you hear
I
me?
think, yeah, sure. Thank you for the case. I think any of the panelists can answer. So maybe anyone want to make any comments on the diagnosis of this patient?
I think this one is a difficult case because the patient lower limb power is full. So of course, CT scan is mandatory. In this case, MRI is also important because you need to know where is this. Sometimes they have these traumatic this right disruption and they're actually in the canal. So without a proper MRI and simply just do a reduction or go in to do reduction, it's actually quite dangerous for this patient. So I would say in this case, I will do an MRI first. Will you do MRI for this patient?
Yes. Next, we have done the CT scan of the cervical spine. Here you can see the all the axial and all sections, and
All right,
anyone, any
Okay.
comment?
please.
Any comments before he shows you the MRI?
Yeah, so it is basically a bifacetal dislocation, almost at the worst. As we say, it is a purge facet. So similar type of picture, at least in the X-ray, it looked like that. But if you wish to know the properly, your cut should go through the joint. This joint is important. Then you will get classically what is the situation of superior and inferior articular process. So if that picture comes, then yes, you will be able to very nicely see those things. Usually this appears to be bifacetal because in unifacetal dislocation, what is the landmark which you can identify nicely even in the plain X-ray, that spinous process, they are not in the same line. You find little bit, change in the alignment of the spinous process. That is the first diagnostic thing for the unifacetal dislocation, apart from in the plain X-ray, apart from seeing the CT, and where you should concentrate on the lateral cuts there where the joint is there. Sometimes there may be associated fracture of the articular processes. So one has to be, knowing that, because that comes to as a locking part, which doesn't allow the, reduction to be done so easily. So one should be aware that whether there is a fracture of the articular process. So that is the second thing. And third thing, as you already mentioned about the status of the disc, because whenever you do closed manipulation, you are fearing about the disc. When it goes totally into the canal, then there are chances of deficit. So I think these 3 points are important for dealing such cases.
Yeah. So
Can
I
you
think
show us the MRI, please?
yeah,
MRI.
everyone. Yeah, can we move on to the MRI?
Next, we can come to the diagnosis and classification according to our CT and X-ray. Or would you like to see MRI, then come to classification? You can show the MRI so that discussion goes faster. The MRI of the cervical spine showing the sections, and
Can you reverse one slide? Oh, sorry, one slide. Yeah. Okay. Forward one slide. Yeah. This one maybe has the MRI of most of the sagittal cuts. Yeah. So maybe the panelists, do you think it is safe to reduce it or not based on this MRI? Anyone?
Yeah, actually, part of disc is still there out. Part of it is the superior surface. It is visible along with the fifth one just over there. I think since we now there is another way of tackling these issues, because when suppose you try to reduce it before surgery, so the better thing would be your theater should be ready, and you are going to give awake traction. So if any deterioration is there, you will be able to intervene immediately. Most of the time, you don't find any problem, and you get the reduction. What happens when you get the reduction before surgery? Your job becomes very easy. You have to just expose and do the ACTF. You have not to manipulate anything intra-operatively. Here, yes, part of the disc is there, but I think it can still be tried. Intraoperatively, it is very easy. You have to just go to the oncovertebral joint and try to manipulate, and it comes there also. So if you wish to play safer, you don't have neuromonitor. Otherwise, also you are going to fix this. So better you can open it. And now see in this cut, the disc is, it's actually part of the disc is only there. The rest of the disc is lying just below the C5. You can see this picture is very good. On the, I'm talking on the this side. There are two, right side and left side. So on the left side, this disc is here in the place. Only part of the, I think, cartilaginous part you are seeing there, the bony part. And these are the actually soft tissue shadow. This is not a disc which is looking behind the C5. It is not a disc. Disc is below the C5.
Dr.
I have a query
Jonayed.
regarding this case. Professor Sudhir.
Yeah.
So suppose this case is motor power is almost normal. Suppose it is 4/5. If
Yeah.
the patient is simply suppose Asia B, suppose only sensory is present, there is no motor power. In that case, your decision. I mean, do you still prefer to reduction, or you will go directly to the
No.
open? I mean, the
See,
operating procedure.
Yeah, actually, this case is very fresh, you know. So in this case, I will definitely try reduction, and most of the
I
time.
agree with you. But if suppose if it is a case with severe motor deficit, in that case, I mean, if there is a more neurological involvement, in that case, do you still try for close reduction or go for directly to the open? Is there any
actually, I will tell you. If the patient is having, significant neurological deficit, and in that case, it is better not to further stretch the cord.
Yes.
Stretch the cord, and you should not try traction. Okay, it is reverse way. One should not think he already totally deficit. What is the harm in doing that? No. Even if it is a incomplete injury because of the spinal shock, it is masked, then we might be further harming him. So it is better not to do better not to do the closed manipulation or give traction. So I think that should be an ideal situation.
So I have another comment. Suppose in our scenario, suppose country like Bangladesh or India is the same scenario. So far literature, they are advocating the very early close reduction. But we are cases that we are present to us, most of the time they are presented late. Suppose 2 days, 3 days, even more than 7 days. In that case, suppose the case presented late. In that case, what is your recommendation? Go close reduction or straightforward operation?
No, close reduction. We have tried even for 3-4 weeks. Because see, in our institute, there was a round-the-clock theater available.
Okay.
We have whole night surgery going on. So we never have any problem, and we can get the theater anytime if suppose something wrong goes. But I think closed manipulation can be tried. Any literature is full of it. If you go through the literature, even the old cases have been reduced. Maximum amount of traction has been given. Everything is there. But one has to be watchful, and one should not leave it to the junior person in turn to observe the patient. No, in that case, a senior person should be around.
So another observation, where you reduce it, is it your the ICU or infrastructure or simply the emergency department or like that?
Emergency department itself. We have caught there. We have caught their traction facility, and by the side there is a theater also.
Okay.
So we can manage.
Yeah, I would like to ask one question to Dr. Srivastava. I agree with your comment that if patient has total neurology or Frankel B, no, you wouldn't reduce it because it may cause further damage without any proper monitoring from the patient. What if patient have Frankel C, bad Frankel C, like grade 1 power? Will you still reduce it in the ER?
No. See, if the patient is having deficit and you have actually support of your MRI, that this has almost gone inside part of only remaining, it will be safer to do the open procedure and take out the disc. Okay. See what happens when this traction is important. First thing, when it is late. Okay. Second thing, there is a dislocation, which you feel it might cause problem, and better to try it, before surgery and see whether it is getting relocated. And in all these situations, the patient is awake, so you will get enough idea whether he has started showing neurological symptoms. Also is important, because when you gradually increase the weight, the patient start telling you that he is giving some tingling, numbness in the limb. Okay, so all these things has to be taken into consideration. Better to open it if you fear anything, and I think you don't lose anything by opening, because otherwise also you are going to fix and fuse these subluxes and dislocation. That will be the safer way to.
So another problem that we frequently observe intraoperatively, that whenever we try to reduce the dislocation, it is reduced, but it seems that it is little bit distracted. So is there any tips so that dislocation will be reduced, but it is not at the expense of too much distraction?
Yeah.
Is there any tips?
Yeah. So in that case, you take help by your Casper distractor screws. Okay. We usually put the Casper distractor there, So
Yes.
you pass the screw and that. You take help of these screws to align it and try to maintain the alignment. So it does help. You got my point?
I understand, because you are starting, suppose, in convergent to divergent, right? Little distracted.
Yeah.
But my question is, as the patient is already under anesthesia, so sometimes it is not possible to measure how much force we have already applied. So it seems that it is I mean the dislocation is corrected, but so much distraction. So,
so
for
in that
anesthetized
case,
patient, is there any?
yes. So see what happens, with the X-ray also, what is the height of proximal and distal disc?
Yes.
What is the distance between the spinous processes? Okay.
Yes.
So you will have to reduce the distraction, or I would say the skull tongue which you have put weight. That once you reduce it, align it, you have achieved the reduction. Then you lessen the weight. The weight which you have applied with the crossfield tongue, that you have to
Professor Sudhir, I am not talking with the closed reaction. I am talking with the.
No. I'm talking about the open only.
Open.
Open. So ask your one of the assistant to lessen the weight over the traction, and even the distractor which you have put, Casper distractor, you just reduce it. Reduce the amount of distraction. Sometimes you find that it is bobbling, it is not coming nicely. Then you keep a small periosteum, put it near the oncovertebral joint.
Yes.
And there you will be able to nicely align it. Okay, that is important.
Yes, I got your point. We are actually doing this. That's why I'm asking. Okay.
Yeah, I think there's some questions from the audience to Dr. Srivastava. But I think you have answered it before. Maybe you can answer it again, because they asked two person asked almost the same question, is that if you are going to go in for surgery, why just reduce it? What is the advantage of reducing it? Yeah, both asking about the same thing. Yeah.
So actually, it becomes easier, a straightforward thing they have to open and do the discectomy and fusion. Sometime, you might fail to reduce. In that case, what happens? You have to turn the patient. You have to turn the patient, go prone again. You dislodge the facet joint and then come again anterior after fixing posterior to put a graft and plate there. So you will be mentally prepared that my everything has been done, and let's just go anterior and do the ACTM. Now, many a times, I would say almost 90% to 95% patients where there was a dislocation, you would be able to reduce after opening. You will not go posteriorly. Many a times, I'm telling. But cases which have arrived to you very late, in that situation, only this is important and vital, that first try to reduce it so the front surgery becomes easier, but there are manual to do it intraoperatively, and many times you are able to achieve the results. So this we wish to, do it prior hand. Moreover, what happens? What is the role of traction? It is not only intraoperative traction which we are looking for. You actually gradually inward when you apply traction, not for this problem, other problem also. The purpose of this traction is gradually stretching the soft tissue. It makes it gently relaxed. Instead of doing acute stretching, the gradual stretching gives time the soft tissue to relax. Okay, so these 2-3 points are there, and I think one should be aware. And one thing is extremely important: you are doing all these things when the patient is awake. Rather, you will try to defer under anesthesia.
Okay, maybe we can move on. What do you do actually? Yeah, the study.
Now we can come forward to classify our what is the classification of this fracture. So in my view, it is a Asia grade D and EU type C, Allen and Ferguson classification, destructive flexion stage 3, subaxial and SLIC score 9. So anyone, any comment regarding the classification of this scenario?
All right.
Okay. So
yeah, so did you do the close awake reduction, or do you go ahead for surgery?
It is under general anesthesia. It is not possible here evac reduction.
Okay, so you didn't do awake reduction.
Yes, sir. This is our operative picture, and it is a post-operative, and it is a pre-operative after 15 days follow-up, and after 6 months follow-up, and 1.5 years follow-up.
Nice.
Okay, can I ask the panelists, anyone would have done a close awake reduction and go posteriorly instead of anteriorly if the close reduction is successful?
See, most of the time what happens, you tend to go just anterior because you have already achieved reduction. Okay. Now, if suppose there is a end plate fracture or something like that.
Yes.
Okay, where you doubt that your reconstruct will be good enough anterior side. In that case, it is better to just go posterior and lateral mass both the side and just compress that area, and that will suffice.
So another thing is that if it is in junctional area, I mean that if it is C71 or like that, in that case you need to augment. So you need to do anterior as well as posterior. That means the combined procedure. Or sometimes if you see that there is already facetal fracture is there, so in that case you might also consider the combined approach or that's it.
Actually, the posterior procedure is a good procedure in the sense that you are putting the implant on the tensile surface.
Yes.
And in maximum situation, I will say 99 to 100%, this doesn't fail unless your hold is bad. Anterior might fail because it is just a buttress plate and screw. So moment the patient does acute flexion, this might change the situation. But the posterior fixation is a better. All biomechanically, all the implant ideally should be put on the tensile surface. So actually, posterior surface of the spine is also tensile surface. So it is a better way of fixing the spine. So as Dr. Jonayed mentioned, that junctional area one has to pay more attention, and it is better to fix the tensile surface.
Yes.
Yeah, most of the time, I figure out that if you have a bilateral fracture dislocation, if you go posterior, it's almost impossible to use a lateral mass screw unless you want to go one level up or one level down. So most of the time, there is a lateral mass fracture, I will have just used a cervical pedicle screw, which is a shorter fusion and much stronger than this lateral mass fixation.
Yeah, you're right.
Okay, thank you very much. I think we have to move on to the next case. Yeah, thank you very much, Dr. Dastagir, for your very good case presentation. Do you have any more slides to show us? Or that's the end? That's all? Yeah, okay. So I'll move on to the next case presenter, will be my co-moderator, Dr. Vijay Loya. He will be presenting another case. Yeah, Dr. Vijay.
Good afternoon, everyone. So today I'll be presenting the last case of this webinar. It's a case on odontoid fracture. This case was done at Chennai Miyot Hospital. So there's a 45-year-old male, presents with a history of RTA, four-wheeler hitting a divider, and presented with a pain in neck. So as Dr. Jonayed was mentioning, 8 years protocol was followed, and patient was immobilized with collar. ABCD was stable, and GCS was 15 on 15. There were no other chest or pelvic injuries. Her abdomen was soft and no appendiceal injuries. So no neurodeficits on initial examination. So as we know by nexus criteria, since there was a midline posterior tenderness, we went ahead with a CT scan. So this was the CT images. So I'll just show axial first, and then I'll show the I'll show the sagittal first, and then I'll show the axial and coronal ones. So since Dr. Brian has already told, but I would like to take opinion of Dr. Dastagir. So what do you think this is what type of classification in Anderson D. Alonso? Dr. Dastagir, would you like to comment something?
It is Anderson type 3.
Yes. Yes, it's Anderson type 3 because it is extending into the facet. So on axial images, there was an injury extending even into C2 left pedicle. As you can see, the injury was extending into the C2 left pedicle. So Dr. Srivastava sir, would you like to comment anything about pre-op planning using CT images?
Yeah. Yes. Actually, you are worried about this pedicle which is fractured, isn't it? So that is the concern you have. But if you go through the other cut, this might be a quite anterior part of this part bone has fractured. So you always have a standby fixation, and that is the laminar screw. One side you pass the pedicular screw, and another side you can pass the laminar screw. And laminar screw also is a good hold. Sometime in fracture, it looks that your screw will not have any purchase, but many times on the table you find that it has good purchase because this section has been taken from one side. So do you have that sagittal cut where the pedicle is nicely visible, lateral mass? Yeah, this side. Okay. So now here, if you see, in fact, you can compress that, with the one side, the pedicle is fractured in such a way that can be actually compressed. So because this is the posterior element fracture also in one of your cut, yes, sir. So it is an atypical type where the fracture is going into the body. In one of the view I just now say, yes. Here in the center, yeah. So in fact, at one side, if you do both the side, it is like that. So if you pass the first K wire and then put the screw, definitely on the right side, you will be able to pass nicely. Left side, if you find there is a problem, in that case, you can pass the laminar screw.
Okay. So I would also like to ask Dr. Jonayed, do you do routine CT scan, MRI scan in such a case to look for TAL integrity or other ligament integrity? Or just a CT would be enough with no neurodeficits?
For this particular case, I will do I will do the MRI routinely to see the fracture as well as the vertebral artery also.
Okay.
Anatomy. That is important as for also the medical legal purpose also.
Okay.
Yeah, but for this case, you're going to do a C1, C2 fusion or without fusion. Just a question to ask.
Yeah. So if we go for the options, let us say the patient is 70 years old with medical comorbids. What is your plan of action, Dr. Brian?
You see, when you show the CT scan, they actually involve the C1, C2 joint. So I think I would definitely go for fusion, C1, C2 fusion. There's no point of removing it after. No point of just instrument and remove the instrumentation later, because eventually patient will have some neck pain, or no. If you look at the slide on the right side, the lowest one, there is involvement of the yeah, correct. There's involvement of the joint there. So I think I'll just do a fusion.
Okay.
Vijay, can
Yeah.
you show coronal? Okay.
Yeah.
Actually, this can be treated without surgery also.
Also, yes.
You see the union rate is very good in type 3. It is not a simple type 2 only. If you see, it has gone into the body, and this part of the subchondral bone is sliced off. So, and if there is no ligamentous injury, no transverse ligament rupture and all those things, which doesn't appear to by seeing the picture of the CT also. I think this can be treated with the rigid cervical collar. I would say Philadelphia collar, not halo. Philadelphia collar, 70 years old male patient, they will not tolerate properly this halo.
Okay.
So I think rigid cervical collar, and when I say rigid, it is Philadelphia. It is holding the, head is very large. The weight of the head is very significant. So it is one of the force now which pushes the things. So always immobilize the occiput and mandible, and for that Philadelphia collar is important.
So anyone in the panelist, are they using Halo West, Dr. Jonayed or Dr. Srivastava, sir? Halo West now, or are you completely abandoned?
Abandoned. I don't use.
Okay. So as Dr. Brian had shown, we can do screw osteosynthesis also, anterior transarticular or odontoid screw, and posterior fusion. Or as we were planning, posterior temporary fusion and future implant removal. So these are the options. So if the panelists can tell me which is the best option or option of their choice, we can go ahead, or just for the discussion sake.
Yeah, first I will ask you only. Why you have put this last choice?
Rarest.
No, it is not required. You have put it. I feel it is unnecessary. Transoral odontoidectomy. Why you want to take out that? It is nicely sitting in its place. Okay. So otherwise, this is a straightforward case. You can even treat it, but if you cannot send this patient, to different, state or different place, because you have to keep him under observation. Okay. And that is important. You have to take the follow-up X-ray and see whether it is line on nicely or not. But he has a very high chance of union, provided he doesn't smoke, he doesn't have significant osteoporosis. Those factors are still very, very important.
Okay. So, Dr. Brian, what would be your, what would you do?
Yeah, in this case, if I would have offer patient operation, I would do a C1, C2 fusion.
Okay. And Dr. Jonayed?
So I will go the anterior
transoral.
Yeah.
Okay. And Dr. Dastagir, if you can also provide your opinion.
Anterior, I will go anteriorly.
So just for the younger surgeons, I just had this slide. So positioning, I think all of us use Mayfield. I mean, no one uses the horseshoe in this case. So pre-op vertebral angiography, we do see whether which is the dominant artery and which is the non-dominant. IONM, though there is a lot of space for the spinal cord, but IONM can be, I mean, it is preferable for all the medical legal reasons. And Dr. Srivastava, sir, for a young surgeon, I would just like to ask this question: how many cases you should do with another surgeon before you can do these cases alone, C1, 2?
I think that this will also depend upon the aptitude of that, new fellow or whosoever there. Some of them, they pick up very fast. Okay. right from the anatomy and how to use the instrument is extremely important. So I think if he assists, 4-5 cases of each variety, I don't think there is any problem in that. Okay. So I think this is all right. Here, what you have mentioned about the muffled or horseshoe, here one has to be very, very skeptical about using the, headrest, what type of headrest. Suppose you wish to, for this is for all, C2 fracture or C1, C2 fracture. Your AP picture should be also very clear. Moreover, when you are passing the odontoid screw, isn't it? So that should not become a hampering thing for you. So that for AP lab, X-ray is extremely important because this is everything is under radiological control. So this is important. And I think, as you asked, I think now the younger generation has assisted few cases. I think there should not be any problem because they are refined one. Only this anatomical area is not that clear. So in that case, one has to understand that properly because vital structures are around the spinal cord, vertebral artery, anomalous vertebral artery. So one should be aware about that. I think if they assist few cases, I think they should be able to do it.
Okay, Dr. Jonayed, what precautions do you take? Sometimes the vertebral venous plexus is very tortuous and it can bleed a lot. So any other intraop hemostasis, any other tips you would like to give other than, the one that is mentioned?
The
Intraop hemostasis in C1.
proper posterior approach.
Yeah, posterior approach.
Proper. So one thing is that during doing the surgery, one of the important things is that you have to do the hypotensive anesthesia. That is very much important in that particular case. And uses of bipolar cautery if it is needed, that is also very much helpful. And sometimes we can also use the adrenaline soaked gauze. That will also helpful.
Okay. The other thing is there, Dr. Vijay, that when you have such type of problem regarding bleeding, keep the head end up.
Up, yes.
Elevate the hand head up, because you might have seen that when you do ACDF and if your head is little down, you get all engorged veins.
Yes.
So keep the head up,
and
you have you are actually planning to fix both the side. So if there is a bleeding, pack one side and work other side. By the time you finish that, you come to this side, this becomes dry. So this is the another tip to do one side and pack if there is a bleeding other side, and then again come to that side. And all, of course, this flow seal, patties, Surgicel, all these help. You just pack it and then you work there.
Yeah. So Dr. Brian, do you do freehand or you do fluoro assisted?
Free fluoro assisted. Yeah. I don't dare to do freehand. Even every advancement of 2 mm, I will just take an X-ray to make sure I'm aligned. I'm not going other place.
Can I give one tip here?
Sure.
Yeah. So what you do in that case, when you can do even the freehand, it is better to have all the gadget. But if you are not having, then what is the way? You make an opening site, and in your set you should have 3 tabs. One is 2.5, another is 2.7, 3.5, like that. Okay. And in that opening, what is the angle of trajectory. And just you start rotating your tab, it will take on its own its path. Because you are in the center going into the cancellous bone. That is the safer way of doing. Instead of drilling, when you drill, you might drill the either lateral or medial cortex. But when you are tapping, you will not go anywhere. It will go only. The important thing is your entry point should be proper. And then when you move the tap, you will go to the proper trajectory without any issue. This is the one way of doing it. And then gradually increase the diameter of your tap.
Just for the sake of discussion, to Dr. Jonayed, do you like to put C2 pedicle screw under direct vision by removing the flavum, or you do mostly fluoro assisted?
So most of the time I do it by fluoro assisted.
Dr. Srivastava, sir, your
opinion? Even if you going through the fluoro assisted only, you might go wrong. Okay. Why I'm telling this? In fact, Dr. Jonayed told that you keep one pen field medial to the pedicle, one lateral to the pedicle. Just know which is the area which you are traveling through. And you are traveling between these two pen fields and you will be going into the pedicle itself. Unless you repeatedly turn your C-arm and check AP lateral, I think you use fluoro, but it is better to have your own anatomical landmark there, and then you
Tactile
go.
sensation is very much important, of course.
Yeah. Just last question, Dr. Brian, biplanar fluoro or just uniplanar?
For which one? For posterior approach?
312 posterior.
Only one CT.
Okay.
Two II is for the odontoid fracture.
Okay.
For anterior approach.
Yeah. So I would just like to take Dr. Srivastava's opinion. Do you consider this like looking at the sagittal alignment before you apply the final rod, before C12, like
this posterior surgery you are talking about, that yes, it is important, because you should not pull it posteriorly, or it should not have elastic component anteriorly. So this alignment is very important. And again, I will give you a trick how to align these unstable fractures. You have tulip of the proximal and distal screw. So what happens when you tighten over the rod? It takes the alignment of the rod. So if you have over controlled it, there will be retrolisthesis. If you have poorly controlled it, there will be anteriolisthesis. So exactly you have to give a proper contouring of the rod, and that makes everything very simple.
Okay, so with all these tips, I'll just show the post.
Yeah, please.
So any comments from the panelist? We just put
this is
C3 lateral mass screw also, like.
Yeah.
I think your C2 construct is strong enough. What makes you extend into C3?
Like we were not sure about the facet, so we just put a lateral mass, and we plan to remove the future, implant removal after documenting fusion on the CT scan, maybe, in the future. We didn't do any decompression. So just an in situ fixation.
I think this is
strong enough.
This is fairly all right, Dr. Vijay. See, it is better to, fix one level more and not doing that than repenting later on. Okay. So always, and in fact, if you see the biomechanics of the even spinal column, or for that matter, any appendicular joint or anything, if you have a dislocation, in that case, 2 level above and 2 level below usually we follow. In a spine, usually single level, if you compress the tensile surface, then there is no issue, and you get a good result. But since your one side was comminuted, it was fractured, and that is the region you have passed the laminar screw. So there is no harm in extending one level down. Okay, and you are not fixing occiput, you are fixing C3. Yeah. It doesn't make any difference, and it is better to be safe.
So if no other comments, I think we can call it a day for today's meeting.
Yes, we can.
Thank you.
Thank you.
So Dr. Chikit, just if you can present the summary statement, and then I'll present the vote of thanks.
All right. Thank you, Dr. Vijay. So in summary, we have covered 3 important aspects of cervical trauma: subaxial cervical facet dislocation, C2 odontoid fracture, and C2 Hangman fractures. I think all the speakers, everyone would agree, have presented very comprehensively and concisely, and we have a lot of discussion throughout this webinar session. So thank you very much, and I think I pass over to Dr. Vijay for the vote of thanks.
Yeah. So Dr. Kwan has left, but we would like to thank Professor Dr. Kwan, and then I would like to thank Dr. Vishal and other members of the online education committee, especially Dr. Sudhir Srivastava sir, Dr. Sharif, Jonayed, Dr. Brian, Dr. Chikit, and Dr. Dastagir. So we'll meet next month on endoscopic spine surgery webinar. Thank you.
Thank you.
Thank you very much.
Thanks a lot.
Bye.
Thanks a lot.
Thank you.
Good night.
Thank you.
Bye.